Today, we're embarking on an essential journey into a topic that truly matters, one that profoundly impacts families and brings crucial understanding.
Absolutely. A topic close to many hearts.
Okay, let's unpack this. Our focus today is to unravel the complexities surrounding the dual diagnosis of Down Syndrome and Autism Spectrum Disorder, often referred to as DS-ASD.
That's right, DS-ASD.
And this deep dive is specially curated for you, our listener in the Cairos Clan community. We know this is a deeply relevant and, well, often misunderstood topic.
It really is. There's a lot of confusion out there sometimes.
And our mission today is to provide clarity, compassion, and importantly, empowering strategies for supporting individuals and families navigating this unique path.
Exactly. Clarity and practical steps.
Our goal is to extract the most important insights from the rich source material provided by your very own Cairos Clan community, offering kind of a shortcut to truly understanding DS-ASD, its nuances, and actionable ways to make a profound difference.
It's true. And what's fascinating here is the journey of understanding DS-ASD. For many families, receiving this dual diagnosis can stir a complex mix of emotions.
I can imagine.
Yeah, there's often a sense of relief, actually. Things that didn't quite fit the typical Down syndrome profile suddenly make sense,
Right, like finding a missing piece.
Exactly. But for others, it can bring confusion or even a renewed sense of grief as they process what feels like another label being added to their child.
That makes sense, too. It's a lot to take in.
It is. So this deep dive aims to demystify DS-ASD, moving beyond just the labels to truly understand the individual experience and to equip you, the listener, with a solid foundation of knowledge.
And where is this knowledge coming from?
All the insights we'll be sharing today come from really comprehensive sources. We're talking expert opinions, cutting-edge research, and invaluable contributions from leading organizations like the National Down Syndrome Congress, Autism Speaks, and various dedicated medical and therapeutic professionals. Solid stuff.
Great. So let's start perhaps with a bit of history. What's truly striking and maybe surprising to many of us is the historical context of DS-ASD.
Oh, definitely. It's quite a shift in understanding.
For a surprisingly long time, there was this widespread and deeply ingrained misconception that Down syndrome and autism simply could not coexist. It seems incredible now.
It does. But it was the prevailing thought. Old textbooks, some even from the 1990s, explicitly stated that this co-occurrence was incredibly rare, almost, impossible in some people's minds.
And that belief had real consequences, didn't it?
Absolutely. It had a real impact. It often led parents to be told their child with Down syndrome might have a severe cognitive impairment if they displayed certain challenging behaviors, but without any further investigation into the possibility of autism.
So no looking deeper.
Essentially, yes. It closed the door to looking deeper, which we now know was a significant disservice to these children and their families. Missed opportunities for the right kind of support.
Okay, so that historical misconception is a crucial starting point.
It is, because today our understanding has completely evolved. We unequivocally know that a person absolutely can have both Down syndrome and autism, no question.
Which raises an important question. Why was there such a persistent misconception for so long? What made it so hard to see?
Well, part of it stems from the diagnostic process itself. Unlike Down syndrome, which is objectively diagnosed with a simple blood test, confirming the extra chromosome, fairly straightforward.
Right, very clear.
Autism spectrum disorder is fundamentally a subjective diagnosis.
Yeah.
It relies heavily on observed behaviors, social communication patterns, and developmental history, often gathered over time by skilled observers.
So it's based on watching and reporting, not a lab test.
Exactly. This observational aspect, combined with earlier limited research and, frankly, a lack of specific diagnostic tools designed for this co-occurrence, contributed significantly to the oversight. People weren't always looking for it, or didn't know how to look for it in the context of Down syndrome.
Okay, so if the diagnosis is observational and our understanding has changed so dramatically, what do the modern statistics tell us? How often does this dual diagnosis actually occur now that we're looking for it?
The prevalence statistics today are truly eye-opening, and they directly contradict those earlier beliefs. Autism in individuals with Down syndrome is estimated to be anywhere from 10 to 25 times more likely to occur than in the general population.
10 to 25 times, wow.
Yeah, it's a huge difference. And to put a finer point on it, A comprehensive 2015 meta-analysis, that's a study that pulls together findings from lots of individual studies, suggested a likely prevalence of around 16% for DS-ASD.
16%, so that's roughly.
Roughly 1 in 8 people with Down syndrome also having an autism diagnosis. Now compare that to the general population's autism prevalence. According to recent CDC reports, that's around 1.7%, or about 1 in 54.
So what does this all mean? It's clearly not rare.
Not at all. It means the prevalence of DS-ASD is substantial. This isn't just a statistical blip. It's a profound reevaluation of how we understand this dual diagnosis, completely shattering those previous misconceptions.
That's a real game changer for families, isn't it?
Absolutely. It makes it absolutely crucial for caregivers, educators, and professionals to be keenly aware of the possibility of DS-ASD and the unique profile it presents. We need to know it's common.
Given that high prevalence, are there specific factors that seem to be associated with this dual diagnosis, maybe gender-related patterns or other early indicators that might give a clue?
That's a good question. Research is ongoing here. Some studies do suggest that autism may be more likely in boys with Down syndrome.
Okay, more common in boys.
Potentially. However, it's important to acknowledge that many studies looking at this specific association are often smaller in scale, and not all of them reach the same definitive conclusion. So the research is still developing.
So suggestive but not definitive yet.
Exactly. Clinically, some professionals do report seeing more boys than girls with the dual diagnosis, but it's an area where we definitely need more robust research. Another associated factor that has been identified, and this is quite significant, is a history of infantile spasms.
Infantile spasms, can you explain that?
Sure. It's a specific and severe type of seizure disorder that develops in early childhood. Research indicates that the presence of infantile spasms appears to be linked to an increased chance of developing autism in individuals with Down syndrome.
So that's a critical piece of medical history for doctors to consider.
Absolutely. It's a red flag that warrants closer monitoring for autistic traits.
That's a very important clinical detail. You also touch on the diagnosis challenge, the fact that autism is diagnosed based on observation and that it can present differently. Does the presence of Down syndrome itself make it harder to spot autism signs? Is there that kind of masking effect you mentioned earlier?
Absolutely. There often is a significant masking effect. And it's a key reason for the diagnostic delays we sometimes see.
How does that work exactly?
Well, the slower developmental trajectory often seen in children with Down syndrome can sometimes make it more challenging to detect typical autism signs earlier on. For example, a delay in language development or maybe inconsistent eye contact might be attributed solely to Down syndrome.
When it could be more than that.
Precisely.
Yeah.
It might actually be signaling an underlying autism spectrum condition as well. And what's fascinating here is that research points to a very distinct autism profile for individuals with DS-ASD.
Distinct how?
For instance, children with Down syndrome often have relative strengths in areas like imitation and using gestures. These social behaviors, which are common and encouraged in the Down syndrome community, can sometimes act as a buffer or kind of socially boost a child.
So they might appear more socially engaged than a child with autism alone.
Sometimes, yes, especially initially. This means the autism might present differently than in individuals with autism alone, making it harder for diagnostic panels to recognize, particularly if they aren't experienced with the dual diagnosis. A child with DS-ASD might still greet you with a big smile, appear social at first glance, and engage in some imitative play.
Which could lead someone to rule out autism prematurely.
Exactly. It can sometimes lead doctors who are less familiar with the dual diagnosis to not investigate further. They might think, oh, this child is social, maybe a bit quirky, but it can't be autism.
So it really underscores the need for clinicians to be specifically aware of how autism presents within the context of Down syndrome.
Absolutely. Looking beyond the superficial social veneer and diving into the quality, consistency, and reciprocity of social interaction and play is key.
Okay, let's unpack this a bit further because for parents and caregivers in the Cairos clan community, these nuances are incredibly important. Many behaviors observed in children with DS-ASD can also be seen in children with Down syndrome alone. So how do we tell the difference? How can you, as an observant caregiver, distinguish between behaviors typically associated with Down syndrome and those that might signal DS-ASD?
That's a critical question, and honestly, it's where careful, nuanced observation becomes paramount. It's not always easy. Let's first identify the commonalities, okay? The areas of overlap where behaviors can be present in both Down syndrome and autism.
Right, the shared features.
Exactly. In terms of behavior and play, you might observe a preference for sameness and routine in both populations. Many children with Down syndrome and those with autism thrive on predictability.
Which is why visual schedules work well for both, right?
Precisely. They might exhibit restricted interests, where their focus becomes intensely narrow on a particular toy, object, or activity, sometimes excluding other engagement opportunities. Repetitive play and behaviors, often called stereotypies, are also common.
Like spinning objects or lining things up.
Yes, things like that, and also challenging behaviors like protesting changes or exhibiting difficulties with transitions between activities moving from playtime to mealtime, for example.
So just seeing those things, liking routine, having intense interests, some repetitive play that doesn't automatically mean DS-ASD, that's a really important clarification for our listeners.
Exactly right. That's the crucial clarification. The mere presence of these behaviors alone does not automatically mean a dual diagnosis. It's really about the degree and impact. Meaning, it's when these behaviors become predictable, extreme, or resistant to change, and they significantly impact a child's ability to learn, socialize, or function in daily life, that a thorough evaluation may be beneficial. It's about the intensity and persistence.
Okay. What about other areas of overlap? Social communication, language.
Good points. In social communication, both groups can show challenges with perspective taking. Understanding another person's feelings or thoughts, or with reciprocal turns in interaction, that natural back and forth flow of conversation or play. Even eye contact, when compared to typically developing peers, can be less consistent or used differently.
And speech and language.
Another area of significant overlap. You might see limited expressive language, or perhaps stereotyped and repetitive utterances, maybe echoing phrases heard elsewhere without communicative intent. Understanding language can also be challenging for both, such as difficulties responding consistently to their name.
Which could be hearing related too, right? Common in Down syndrome.
Absolutely. Fluctuating hearing loss is common and needs checking. Or difficulty following long, complex directions. Beyond that, sleep issues, difficulty falling asleep, frequent waking, and sensory issues, like being highly sensitive to certain sounds or textures, are common in both populations.
And mental health.
Yes. We also see higher rates of mental health needs like anxiety or obsessive-compulsive disorder, OCD, in both groups. Again, the key differentiator isn't necessarily if these things are present, but the degree, the intensity, and the persistence of these behaviors. How much do they interfere with life?
That's a really important distinction. It's not just the presence of a behavior, but its quality, its intensity, and its impact. So if we're moving beyond these commonalities, what are the key markers? The specific qualitative differences that are more consistently associated with DS-ASD and might warrant further investigation.
Right. This is where it gets more specific to DS-ASD, though remember, it's a spectrum. When we pinpoint key markers more consistent with DS-ASD, we look for qualitative differences that are less typical for Down syndrome alone. In social communication and interaction, a primary indicator can be little or inconsistent interest in communicating with others.
What does that look like in practice?
It can manifest as significant social withdrawal, maybe an apparent indifference to people entering or being in the room, or requiring others to really work harder to engage them in any kind of interaction. A parent might describe feeling like they constantly have to chase their child for engagement, rather than the child initiating or readily responding.
Less seeking out of social connection.
Exactly. You might also notice significantly less social referencing and joint attention.
Can you break those terms down?
Sure. Social referencing is checking in with a caregiver's facial expression in an uncertain situation. Joint attention is sharing focus on something with another person, like looking where someone points or pointing something out to share interest. In DS-ASD, the child might not shift their attention naturally from a toy to a person, not check in with others to gauge their reaction, or not look up when someone enters the room and actively engage with their presence.
More focused on objects than people, maybe?
Often, yes. The focus might be more intently on objects. They might not turn to look at someone for help, instead trying to solve a problem entirely on their own, even if struggling. And a classic, very telling example here is using others' hands as tools.
Using hands as tools?
Yes. Instead of communicating their want or need through pointing, sounds, or words, a child might physically take an adult's hand and use it almost like an object to open a door, to get a desired toy from a high shelf. Maybe even to make a doll cry by using the adult's hand to wipe the doll's eyes.
That's fascinating. It seems like a fundamental difference in understanding social interaction.
It is. It can often be seen as quirky or even cute by others who don't recognize its significance, but it's a potential marker of a lack of understanding of others as social agents, and can indicate limited symbolic understanding.
That's a profound difference. It's about the intent behind the interaction, or the lack of it, and the ability to see others as partners in play or communication.
What about those restricted or repetitive behaviors? How do they differ in quality or intensity in DS-ASD compared to DS alone? Great question. In DS-ASD, you often see a more distinct lack of symbolic or pretend play, or what we often call less functional play,
Meaning?
meaning toys aren't used as they are typically intended. For instance, a child might spin the wheels of a toy car repeatedly for extended periods instead of pushing the car along the floor and making vroom, vroom noises. They might be fixated on lining up objects, blocks, cars, anything in precise rows over and over.
Or throwing things just to see them fall.
Exactly. Or endlessly throwing things for the simple cause and effect reaction, struggling to move past that early exploratory stage of play. While cause and effect play is normal for all children initially, kids with DS-ASD often have significant difficulty progressing beyond it into more imaginative or representative play, like feeding a doll or having a tea party.
Okay, and the repetitive movements themselves, the stereotypes.
We might also observe higher rates and different qualities of stereotyped behaviors or self-stimulatory behaviors, often called stims. These can include things like hand flapping, repetitive twirling or spinning, head shaking, or whole body rocking, sometimes specific, unusual tics.
And the key difference in DS-ASD is?
Crucially, in DS-ASD, these behaviors are often more frequent, more complex, or unusual in their form, and significantly harder to redirect compared to similar behaviors sometimes seen in individuals with Down syndrome alone.
Harder to interrupt or shift their focus.
Exactly. You might briefly distract a child from spinning, perhaps get them to look at something else for a second, but they immediately return to it with an intense, almost driven focus. For example, a child might repeatedly spin themselves on a step stool for long stretches. Even when briefly interrupted and asked to dance, they quickly return to the spinning. That resistance to redirection is key.
Okay, like they're compelled to do it.
It can seem that way. Similarly, in a playground setting, a child might continue a repetitive action like spinning on a roundabout over and over, seeming oblivious to or uninterested in other engaging activities and peers around them. While maybe 60% of children with Down syndrome alone might show some self-stimulatory behavior, in DS-ASD, it tends to be more pervasive, more intense, and much more resistant to interruption or redirection.
So again, it's not just the presence of the behavior, but its intensity, persistence, and how difficult it is to shift their focus.
Right.
What about sensory challenges? How are they distinguished in DS-ASD? Are they more severe?
While sensory issues can certainly be present, and often are, in Down syndrome alone, things like sensitivity to textures or sounds, they are frequently described as more disruptive and more globally impactful in DS-ASD.
More disruptive how?
This could involve being profoundly overwhelmed by sudden loud noises, things like crying babies, unexpected laughter, singing, or even everyday sounds like a vacuum cleaner or a public bathroom hand dryer. This might trigger intense distress or meltdowns. They might show significant resistance to physical affection, like actively avoiding or pushing away cuddles or hugs, even from trusted caregivers.
Which can be really hard for families.
Incredibly hard.
Yeah.
Or strongly avoiding personal grooming tasks like hair brushing, nail trimming, or teeth brushing due to the sensory input involved. And strong aversions to specific smells, tastes, or textures are very common.
Leading to feeding issues.
Often, yes. Leading to significant feeding issues with very limited food choices. This can become a major family concern and stressor. They might only eat crunchy foods or only soft purees, refusing almost everything else based on texture or smell.
And are behavioral challenges also amplified or present differently in DS-ASD compared to DS alone?
Yes. Behavioral challenges are also typically described as more disruptive and more persistent in DS-ASD. This can include frequent and intense tantrums, often described by parents as meltdowns or drop and flops, where the child might suddenly cry intensely or literally fall to the ground and refuse to move when agitated, overstimulated, or when a routine is disrupted.
More extreme reactions to seemingly small things.
Often, yes. Running away or eloping without warning can be a significant safety concern. And sometimes self-harming behaviors like head-banging, scratching, or biting themselves can be present and more severe or persistent than typically seen in DS alone. A defining feature for many is an extreme difficulty with even minor changes in routine. Unexpected detours, a different therapist, a substitute teacher, these can trigger significant distress.
It sounds like a much higher level of anxiety and difficulty regulating.
That's often the case. They might appear perpetually hyperactive, display high levels of anxiety that are difficult to soothe, or have more significant difficulties with self-regulation in general, leading to more frequent and intense outbursts or shutdowns.
It sounds like a more globally significant presentation across cognitive, social, and behavioral domains. So, how do individuals with DS-ASD compare not just to those with Down syndrome alone, but also maybe to individuals with autism alone? Because it seems to be this unique blend, right?
That's a truly fascinating and critical comparison. When looking at DS-ASD versus Down syndrome alone, as we've discussed, individuals with a dual diagnosis often experience greater and more profound difficulties with communication, social engagement, sensory sensitivities, and behavioral challenges. They also tend to have more significant cognitive challenges and slower processing speeds compared to their peers with Down syndrome alone.
And that slower processing can be mistaken for something else.
Exactly. It can sometimes be misinterpreted as stubbornness or defiance when it's actually a processing delay. They need more time to understand and respond. Now, if we connect this to the bigger picture and compare DS-ASD to autism alone, what's truly striking here, and maybe counterintuitive, is that individuals with DS-ASD may actually show more overt social interest in peers and display less severe repetitive behaviors than many individuals with autism alone.
Really? More social interests.
Sometimes, yes.
Yep.
For instance, while a child with classic autism might seem to completely ignore other children, a child with DS-ASD might still approach and attempt to engage, perhaps even frequently, even if their attempts are atypical, maybe awkward or not sustained. They might want to be near others, even if they struggle with the how of interaction.
So that could make diagnosis even trickier.
It absolutely can further complicate the diagnosis, as they don't always fit the typical autism alone profile that many diagnosticians are primarily familiar with. However, they generally have more significant global cognitive challenges and more pronounced language delays than individuals with autism alone.
So it's this unique constellation of features.
Precisely. This unique presentation, a blend of features from both conditions, really underscores why specific expertise in DS-ASD is so vital for accurate diagnosis and truly tailored support. You need someone who understands both conditions and how they interact.
So what does this all mean if you're a caregiver in the Cairos clan community and these signs, these descriptions are resonating with your experience? What's the practical next step if you have concerns simmering?
Okay, yeah, this is crucial. If these concerns are resonating, the first and most important step is to discuss them thoroughly with your pediatrician or primary care physician. Don't hesitate.
And how should parents prepare for that conversation?
It's crucial to prepare. Observe closely, take detailed notes, maybe keep a journal for a week or two on specific behaviors you're seeing. Note when they occur, what seems to trigger them, how long they last, and importantly, how they impact your child and your family. Arm yourself with current information about DS-ASD. Maybe even print out some reliable articles or resources to share.
Because not all doctors might be up to speed.
Unfortunately, yes. Not all medical professionals are equally informed about this dual diagnosis, so bringing information can be helpful. Be persistent if your concerns aren't initially addressed.
Okay, so you talk to the pediatrician. Then what? Who actually makes the formal diagnosis?
Right. Once you discuss your concerns, a formal autism diagnosis requires evaluation by a professional specializing in autism assessment. This could be a developmental pediatrician, a pediatric neurologist, a clinical psychologist, or a child psychiatrist.
And is there a key question to ask when looking for someone?
Yes, absolutely. When seeking an evaluation, it is absolutely essential to ask potential providers. Do you have experience evaluating autism in a person or child with Down syndrome?
Why is that specific experience so important?
Because, as we've discussed, the presentation is unique. This specialized experience is key to a proper and accurate assessment. They'll be familiar with the nuances, the overlaps, the masking effects we talked about. Not every autism specialist is familiar with DS-ASD, and finding someone who is can significantly impact the diagnostic process and the usefulness of the final report and recommendations.
And where can families in our community find these specialized resources, or even just connect with others who understand this unique journey?
Finding the right people can feel daunting. A great starting point for finding qualified evaluators is often the Association of University Centers on Disabilities, the AUCD network. These centers usually have multidisciplinary teams specializing in developmental diagnoses.
Like university hospitals.
Often, yes, or affiliated centers. Many families also find support through developmental pediatricians or specialized Down syndrome clinics, which are increasingly recognizing the need for DS-ASD expertise within their teams. You might also consider seeking an educational diagnosis from your local school system.
An educational diagnosis, how does that work?
Sometimes the school evaluation process can identify autism for the purposes of school services, which can unlock school-based supports even before a full medical diagnosis is complete. It's another avenue to explore.
And other resources, online communities.
Definitely. Additional invaluable resources include Autism Speaks, which has general autism information. But more specifically, the Down Syndrome Autism Connection, they offer fantastic online support and resources specifically for families with DS-ASD, including private Facebook groups where you can connect directly with other parents who truly get it.
That peer support must be huge.
It's immense. There are also specialized clinics cropping up, like Charlie's Clinic, focused on this population. And there are helpful books available, like When Down Syndrome and Autism Intersect, which is considered a really comprehensive resource written by experts in the field.
Knowing how complex and sometimes lengthy the diagnostic journey can be, why push for it? Why pursue a formal diagnosis? What are the profound, tangible benefits for the family? And most importantly, for the individual? Why go through that process?
That's a really important why. A formal diagnosis is profoundly beneficial for several reasons, and it goes far, far beyond just getting a label. First, it legitimizes family concerns. It provides validation for what parents have been observing, sometimes for years.
So it confirms their instincts.
Yes, and that can be incredibly powerful. It can open doors to a much broader community and network of support from other families navigating similar challenges, reducing that sense of isolation. More fundamentally, it helps parents and family members better understand, support, and guide their loved one.
How so?
It helps explain why their child might be developing or acting differently than their peers who only have Down syndrome. This understanding can shift perceptions, maybe moving from seeing a behavior as stubborn or difficult to understanding this is how their brain is wired, and here's how we can help them. It fosters empathy and more effective parenting strategies.
And practically, does it unlock different supports?
Crucially, yes. A formal diagnosis provides access to critical strategies, interventions, and therapies that are specifically tailored to DS-ASD and have been shown through research to improve outcomes. These might include specialized approaches in applied behavior analysis, ABA, specific types of occupational therapy focusing on sensory integration, and targeted speech and language therapy focusing on social communication.
Things they might not get otherwise.
Potentially, yes, or they might get less effective, more generic versions. Furthermore, it helps health and educational professionals create appropriate individualized goals and strategies within therapy plans and individualized education programs, or IEPs. These plans can then truly support the individual's unique learning and developmental needs based on both diagnoses.
So it leads to better targeted help.
Exactly. Without a formal diagnosis, access to these tailored services and essential resources can be significantly limited, making the path much harder and potentially delaying progress.
You've laid out a powerful case for the immense benefits of early and accurate diagnosis and intervention. Yet we know a common frustration for families in our community is that lengthy diagnostic journey. Why is it that, even with all these benefits, many individuals with DS-ASD receive their diagnosis much later, often well into their teens? It's such a stark contrast to typical autism diagnoses happening around age 2 or 3.
You've hit on a critical and often heartbreaking reality for many families. It's true, the common average age for a DS-ASD diagnosis is estimated to be around 14 years old.
14? That's years of potentially missed intervention.
It is, and it's starkly different from the average age for an autism alone diagnosis, which, as you said, is typically much earlier, around 2.5 years old these days. There are several significant contributing factors to this common late diagnosis.
What's the main one?
One is the slower developmental sequence inherent in Down syndrome itself. Because overall development often progresses at a slower pace, the specific signs of autism might not be as clear or pronounced at the typical age when autism is often diagnosed in the general population.
Can you give an example?
Sure. A child with Down syndrome might not be speaking much at age 2 or 3. While that's also a common autistic trait, in the context of DS, it might be attributed solely to the Down syndrome, making it harder to discern if autism is also present, especially in those early years. The picture becomes clearer later, but that means delays. And this raises an important question. Another major reason for late diagnosis is a phenomenon we call diagnostic overshadowing.
Diagnostic overshadowing? What's that?
This is where one existing diagnosis, in this case Down syndrome, is used, often unintentionally, to explain away behaviors that are actually indicative of autism.
So attributing everything to the Down syndrome.
Exactly.
Yeah.
For example, if a child with Down syndrome doesn't consistently respond to their name, or struggles with making eye contact during interaction, or has intense meltdowns over routine changes, it might be attributed solely to their Down syndrome by professionals or even family members. This leads to missed opportunities for further, more specific assessment for autism.
And that causes problems down the line.
It really can. As one expert we reviewed mentioned, this can cause a lot of big problems because it delays crucial, tailored interventions that could really help. Families are often told by well-meaning but perhaps less informed professionals, oh, it's just a Down syndrome thing, when in reality, it's a distinct autistic trait that needs specific strategies and understanding.
That sounds incredibly frustrating and honestly disempowering for families who are often already noticing something different, something beyond what they might expect with Down syndrome alone. They know something else is going on.
It absolutely is.
Yeah.
And compounding this, sometimes parents themselves may still be coping with the initial Down syndrome diagnosis, the emotional and practical adjustments it requires, and simply not be ready, emotionally or logistically, for another significant diagnosis right away.
That makes sense. It's a lot to process.
It is. There's also still a pervasive lack of awareness, not only among many parents, but even some medical and educational professionals, that the two conditions can co-occur at such a high rate. If they're not aware that DS-ASD is a real and common possibility, they simply aren't actively looking for the signs. They don't have it on their radar.
Out of sight, out of mind, essentially.
Somewhat, yes. And finally, for parents, there are often limited comparison groups, especially early on. A family might only know a few other children with Down syndrome, making it harder to spot subtle but significant differences in their own child's social style, play patterns, or sensory responses that might signal a dual diagnosis. They might attribute their child's unique quirks just to their individual personality within Down syndrome, without recognizing them as potential distinct autism markers.
So when a family does pursue an evaluation, maybe overcoming some of these hurdles, what assessment tools are typically used to diagnose DS-ASD, given these complexities and the unique profile we've described? It can't be straightforward.
No, it requires a thoughtful approach. When an evaluation is pursued, several tools can be helpful, often used in combination by a multidisciplinary team, maybe a psychologist, a developmental pediatrician, a speech therapist. The MC chat, or modified checklist for autism in toddlers, is often used as an initial screening tool, especially in primary care.
But does it work well for kids with DS?
It has limitations. It's important to acknowledge that it may flag language issues commonly seen in Down syndrome, even without autism being present. So a positive screen needs careful interpretation. Nonetheless, it can still be useful for identifying other red flags related to social interaction or repetitive behaviors that warrant a closer look.
Okay, so it's a starting point, maybe. What else?
The Social Communication Questionnaire, or SEQ, is another valuable tool. It's a 40-item parent screener that asks about behaviors typical of autism across development. The Aberrant Behavior Checklist, the ABC, is particularly useful because it has been validated for use in individuals with intellectual disability, making it highly relevant for this population. It helps quantify challenging behaviors like irritability, lethargy, or hyperactivity.
And what about direct observation tools, the ones where they play with the child?
Right. The gold standard for direct observation is often considered the ADOS, the Autism Diagnostic Observation Schedule. This is a semi-structured, standardized assessment. It involves structured play and activities specifically designed to elicit social communication behaviors and look for restricted or repetitive behaviors associated with autism.
Is the ADOS validated for Down syndrome specifically?
That's a good point. It's not specifically validated for Down syndrome. However, many experienced clinicians find it to be an incredibly appropriate and insightful tool for evaluation in this population anyway. It provides valuable, direct observation of those core autism features in a structured way. It's important for parents to remember, though, that a diagnosis doesn't require every single symptom to be present.
Because it's a spectrum.
Exactly. Autism is a spectrum, and a diagnosis is made when enough symptoms are present across different areas to meet a certain threshold or score, indicating a significant impact on the person's functioning and development. It's about the overall pattern.
Before jumping to an autism diagnosis, based on these tools, it sounds like it's incredibly important to rule out other medical conditions first. I imagine some behaviors might overlap with other health issues common in Down syndrome, and that could lead to misdiagnosis or delay proper treatment for something else entirely.
Absolutely, 100%. It's a critical first step, maybe the most critical initial step, and one that cannot be emphasized enough. You must rule out underlying medical conditions commonly associated with Down syndrome, as these can significantly affect behavior and development,
Mhm.
sometimes mimicking autism signs very closely.
Like what kind of conditions?
Well, it's often said in clinical practice, all behavior is communication. We need to ensure a child isn't acting out or withdrawing or having meltdowns because they're in pain or can't see or hear well or are unwell. So at a bare minimum, comprehensive vision and hearing screens are essential. Uncorrected sensory deficits can profoundly impact social engagement, learning, and communication.
Okay, vision and hearing checked. What else?
Thyroid function tests should also be performed regularly. Hypothyroidism, an underactive thyroid, is quite common in Down syndrome and can cause symptoms like lethargy, cognitive slowing, constipation, and behavioral changes that could be mistaken for depression or lack of motivation or even autistic withdrawal.
Makes sense. Any others?
Definitely. Other common medical conditions to consider and rule out include obstructive sleep apnea and other sleep difficulties. Poor sleep can lead to irritability, hyperactivity, and attention problems during the day, looking a lot like ADHD or anxiety. Celiac disease, which is an autoimmune reaction to gluten, is also more common and can cause significant GI distress, pain, and behavioral changes if untreated.
GI issues seem really common.
They are. Trouble swallowing or chewing effectively and very low muscle tone hypotonia can also influence a child's comfort, energy levels, feeding, and overall engagement. Seizure disorders, which can sometimes present atypically or subtly, maybe as staring spells or sudden changes in behavior, need consideration. And chronic pain conditions like arthritis, especially as individuals get older, can also cause irritability and behavioral shifts.
What about mental health conditions that might overlap?
Good point. Behavioral and mental health conditions such as ADHD, depression, and anxiety are also more common in Down syndrome, and their symptoms can certainly overlap with or exacerbate autistic traits. Difficulty with attention, impulsivity, persistent sadness or worry, these can significantly influence a child's behavior and emotional regulation.
So treating these things first could make a big difference.
A huge difference. Treating these underlying medical or mental health conditions, often with appropriate medication managed by a specialist or through dietary changes like for celiac disease or using a CPAP for sleep apnea, can often lead to substantial improvements in behavior, learning, and overall well-being. It can clear the picture, allowing therapists and educators to address the core features of DS-ASD more effectively. So, before definitively concluding DS-ASD, we need to be thorough and ensure we haven't missed a treatable medical reason for a child's presentation. It's foundational.
This raises an important question then. Once a diagnosis of DS-ASD is made, or even if it's strongly suspected while ruling things out, what can families in the Cairos clan community do? What are the proactive ways to support their loved ones effectively? What are the foundational principles and practical strategies that can make a real difference day to day?
Right. This is where empowerment truly begins, moving from understanding to action. When we think about foundational principles for intervention, it's essential to start with a long-term perspective. What do you envision for your loved one's future?
Big picture goals.
Exactly. For many families, common long-term goals include achieving the highest possible quality of life, increasing independence in daily tasks, self-care, maybe work or volunteering, and ensuring safety in their home and community.
And how do you get there?
You break it down. From that long-term vision, you create achievable short-term objectives. Things like maximizing communication abilities, supporting social functioning and understanding, improving self-care skills like dressing or feeding independently, or increasing attention span and compliance with simple instructions. These goals must be individualized based on the person's specific strengths and needs, and importantly, they need to be functional relevant to their daily life.
Makes sense. Individualized and practical. And beyond the goals, what about the immediate environment? You mentioned sensory needs earlier. How crucial is managing the environment for a child with DS-ASD?
Regulating the environment is absolutely paramount. I'd almost call it a non-negotiable first step for effective learning and well-being. It's vital to create a consistent, predictable learning and living environment that is free of unnecessary distractions.
Why is that so critical?
So the child can be well-regulated and remain focused on learning and interaction. Sensory needs are fundamental for learning. Think about it. If a child is constantly dysregulated because they're overwhelmed by noise or under-responsive and seeking intense input, they simply won't be able to learn effectively or engage meaningfully with others.
Like trying to learn math during a rock concert.
Exactly. It's incredibly difficult.
Yeah.
For our kids with DS-ASD, they often need direct help recognizing their own signs of dysregulation, maybe fidgeting, withdrawing, getting louder, and then learning tools to manage it. This could be through sensory strategies like wearing headphones, using a weighted lap pad, taking movement breaks, deep pressure activities, or having a designated quiet time for space. Establishing clear routines and using visual schedules, as we mentioned, can also significantly reduce anxiety and help them anticipate what comes next, making the world feel safer and more predictable.
You also strongly emphasized addressing those medical conditions earlier. How do those fit into the ongoing support strategies? Is it a one-time check?
Definitely not a one-time check. Addressing underlying medical issues is a continuous principle. We must remain vigilant and continually consider medical reasons for any significant behavioral changes or especially any regression in skills.
So, always keep medical possibilities in mind.
Always. This means ongoing monitoring for conditions like sleep apnea, maybe through sleep studies if concerns arise, regular checks for thyroid problems, watching for signs of pain that might indicate arthritis or GI issues, being aware of potential neurological conditions like seizures, which might present subtly, and also monitoring for those co-occurring mental health conditions like ADHD, depression, or anxiety.
And treating those continues to be important.
Absolutely. Treating these conditions effectively, often requiring collaboration between pediatricians, specialists, and therapists, can lead to substantial ongoing improvements in behavior, attention, mood, and overall well-being. This, in turn, paves the way for more effective therapeutic interventions like ABA or speech therapy. Ignoring these potential medical factors is like trying to build a house on shaky ground. The foundation needs to be solid.
Okay, solid foundation. Check medical, manage environment, set goals. Now let's talk about those specific therapeutic interventions. Where do families often find the most help? And what specific approaches are particularly beneficial for the unique needs of DS-ASD?
Applied behavior analysis, or ABA, is consistently one of the most frequently reported helpful interventions by parents of children with DS-ASD in surveys and studies.
ABA gets talked about a lot. What exactly is it in this context?
It's a broad, evidence-based approach focused on understanding why behaviors happen their function, and then using systematic strategies to teach new, more adaptive skills and reduce challenging behaviors. It breaks down complex skills into smaller steps and uses positive reinforcement. For families, one particularly structured parent training program based on ABA principles is called RubyI Research Units on Behavioral Interventions.
RBBI. Tell me more.
It offers about 11 core sessions, teaching parents specific ABA techniques to manage disruptive behaviors, like tantrums or noncompliance at home. It has shown significant promise in reducing these behaviors in children with autism, and its parent training format makes the strategies more accessible for families, even if intensive. One-on-one ABA therapy isn't always readily available or feasible. It empowers parents.
That sounds very practical. What about occupational therapy, or OT? How does that specifically address the unique sensory and motor needs often seen in DS-ASD?
Occupational therapy, OT, plays an incredibly crucial and often very comprehensive role. OT helps individuals across the lifespan do the things they want and need to do through the occupations of daily life.
Occupations meaning?
For children, this includes developing essential fine and gross motor skills, mastering activities of daily living, ADLs, like self-feeding, dressing, bathing, and hygiene. It also involves developing play skills, enhancing cognitive abilities like attention and problem solving, improving social skills and interaction, and building school readiness skills like sitting or using classroom tools.
So very broad. How does it connect to the DS-ASD profile?
A key aspect of OT in DS-ASD is addressing the child's unique response to sensory stimulation, which is often significantly different. Some children might be hyperresponsive, meaning their brain fails to adequately register or respond to sensory input.
What does hyperresponsive look like?
They might constantly touch or mouth objects, non-food objects, bump into walls or furniture seemingly without noticing, crash into things, or seek intense forms of movement like spinning or jumping constantly. They need more input to feel regulated.
And the opposite, hyperresponsive?
Right. Others are hyperresponsive, where their brain registers sensations too intensely. This leads them to avoid touch or certain types of movement, cover their ears frequently, or be easily overwhelmed and distressed by typical levels of sound, light, or textures in clothing or food. They need less input or carefully managed input. OT helps figure out this sensory profile and develop strategies.
Those are such important distinctions for understanding behavior. Can you offer some actionable OT-type strategies for those sensory needs that parents could try at home, drawing from the source material we looked at, like practical tips?
Certainly. And these are often part of what an OT would recommend in a sensory diet. For children exhibiting oral-seeking behaviors, constantly chewing on non-food items, mouthing things you can offer safe alternatives. Things like chewy tubes or specially designed chewable necklaces. Providing deep pressure to the face through gentle massage or using vibration tools around the mouth can help. Offering crunchy foods like pretzels, carrots, nuts, if age-appropriate and safe, of course, or even chewy candies like Laffy Taffy can satisfy that need. Drinking thick liquids like smoothies through a straw also provides strong oral input.
Okay, good ideas for oral seekers.
Mhm.
What if a child refuses to touch things or hold items?
If a child shows refusal to hold items or has difficulty manipulating objects, maybe due to tactile sensitivity, an OT might suggest providing deep pressure to their hands, first squeezing firmly, using weighted gloves briefly, or hand massage. Using vibration from toys, like those little vibrating animal toys, on the hands can sometimes increase sensory awareness and tolerance. Offering play with varied textures, Play-Doh, sand, water beads, shading cream within their reach without forcing interaction can encourage exploration and gradually desensitize their hands over time.
Makes sense. What about kids who seem to seek out intense physical input, the ones who are purposely banging or pushing objects with a lot of force?
Right, the crashers and movers. For those children, strategies include giving them appropriate, safe outlets for that need, filling a wagon or box with heavier objects for them to push or pull around the house or yard. Having them wear a backpack with a few heavy books for short periods can provide calming, proprioceptive feedback. Applying deep pressure through deep squeezes, bear hugs, or using weighted blankets or lap pads can be organizing. Engaging in activities like jumping on a small indoor trampoline, playing tug-of-war, or pushing against a wall provides that needed heavy work input.
So channeling that energy appropriately.
Exactly. If there's excessive movement, constant fidgeting, inability to sit still, providing opportunities for controlled, rhythmic movement can help regulate them. A child-sized rocker, a rocking horse, or slow rhythmic rocking with an adult applying deep pressure can be very soothing. Weighted blankets used appropriately and rhythmic songs or music can also promote a sense of calm and body awareness.
And what about visual seeking? Kids who stare intently at lights or dangle objects.
For those looking intently into bright lights or dangling objects repetitively, you might provide safe alternatives. Maybe offer bright light-up toys with switches they can control. Applying deep pressure over their hands when they start to dangle objects can sometimes redirect. Or help them place objects inside containers for shaking, opening, closing, and hiding, giving a more organized, purposeful action to the visual exploration.
So the goal is understanding the sensory need and meeting it safely and functionally.
Precisely. As a child learns to process sensory input more effectively, often through OT intervention and consistent use of these strategies, their ability to regulate, engage with their environment, and use their hands and body generally increases. This leads to better learning, improved motor skills, and often less disruptive behavior because their underlying sensory needs are being met.
Feeding can be such a monumental challenge for many families, especially with the significant sensory issues often involved in DS-ASD. How does OT specifically address sensory feeding difficulties, and what practical strategies can parents employ there? It's a huge source of stress.
It really is. Sensory feeding difficulties are indeed quite common and can dominate family life. As we touched on, some children might be hyposensitive in their mouth. They might not register food properly, leading to issues like liquid pooling in their cheeks without them noticing, or overstuffing their mouths because they don't get enough sensory feedback to know when it's full. This can be a choking hazard.
And hypersensitive.
Others are hypersensitive. They might experience an increased or easily triggered gag response. They might refuse many foods based purely on texture, lumpy, sticky, wet. They might have difficulty progressing from purees to more textured foods. They can become very particular and restrictive, sometimes eating only a handful of specific foods, often things like chicken nuggets, fries, or bland carbohydrates, which obviously leads to nutritional concerns.
So how can OT help break through that? It sounds so difficult.
It requires a lot of patience and a systematic approach. Strategies to improve food acceptance often start well before food even enters the mouth. It's about reducing fear and anxiety around food first. We might begin with just visual exposure, tolerating the new or non-preferred food, simply being on the table, then maybe on their plate but not needing to touch it. Using pictures of food can also help. Then we move to olfactory exposure, introducing mild, non-aversive smells of the food nearby. Then maybe tactile play, not necessarily with the food itself initially, but maybe playing with things that have similar textures, like cook spaghetti, Play-Doh, or finger paint to desensitize their hands first.
Okay, so gradual exposure without pressure.
Exactly. And then very slowly, oral exposure. This involves a careful progression,
Hmm.
maybe just touching the food with the lips, then kissing it, then licking it, then taking a tiny bite and maybe spitting it out and eventually chewing and swallowing. It's a very slow, patient, play-based process, often called food chaining, or using the SOS, sequential oral sensory approach. The key is no pressure to eat.
That sounds like it takes time. Are there general feeding strategies that help too?
Yes, general feeding strategies are also really important. Setting a consistent feeding schedule, regular meals, and planned snacks helps avoid grazing all day, which can interfere with hunger cues. Ensuring a supportive chair at the table with proper posture feet supported, hips and knees at 90 degrees is crucial for stability and safe swallowing. Limiting mealtime to a consistent duration, maybe 20-30 minutes, and snacks to 10-15 minutes helps prevent prolonged food battles. Minimizing distractions like screens during meals is key.
What about involving the child?
Absolutely. Involving the child in age-appropriate food prep, washing vegetables, stirring can sometimes increase their interest. Rewarding positive behaviors around food, even just tolerating it on their plate or touching it, is important. Considering the presentation, sometimes separating foods on the plate helps, or using fun cookie cutters. And using the rule of 3 for trying new foods can be helpful, offering a new food multiple times, maybe prepared slightly differently, before deciding if it's truly disliked, rather than just unfamiliar. Consistency and patience are vital.
That's incredibly practical and detailed. Thank you. What about speech and language therapy, or SLP, for children with DS-ASD? Are there specific approaches or focuses that are more effective given their unique communication profile we discussed earlier?
Yes, absolutely. Children with DS-ASD often need additional or different approaches to treatment compared to therapy designed solely for Down syndrome or solely for autism. Their profile is unique.
How so? What's the different focus?
While traditional speech therapy might focus heavily on, say, articulation, how clear sounds are for many children with DS-ASD, the foundational aspects of communication are the primary barrier. So therapy goals frequently need to focus on those foundational or pre-linguistic communication skills first.
Like what specifically?
Things like developing consistent eye gaze as a means of nonverbal communication or social connection, teaching them to use gestures, meaningfully pointing, waving, nodding, helping them understand and use facial expressions to convey emotions. Crucially, developing joint attention, that shared focus on an object or event between two people, which is fundamental for learning language and social interaction. And fostering shared enjoyment, finding pleasure in the simple back and forth of interacting with another person.
So building the social motivation and basic tools for communication first.
Exactly. Goals should always be functional, meaning they should promote the child's engagement and participation in daily life, teaching them practical ways to communicate their wants and needs, maybe requesting juice, asking for help, commenting on something interesting in real-world contexts, rather than just labeling pictures in a therapy room.
And you mentioned their communication differences earlier.
Right. We need to directly address those significant social communication impairments, often seen challenges with imitation, joint attention, initiating interactions, and showing shared enjoyment. They also often show limited symbolic communication using gestures, body language, and eye contact effectively beyond just expressing basic needs. The goal is to build that fundamental back-and-forth communication, the social reciprocity, even if it doesn't involve spoken words initially, because communication is so much more than just speech. It's about connecting with others.
And beyond traditional therapies like OT and SLP, what about visual supports and alternative communication aids? I know these are often transformative for children with autism. Are they just as crucial here?
They are absolutely vital and often truly transformative for individuals with DS-ASD. Visual schedules, as we mentioned briefly before, are frequently described by parents as a lifeline, a blueprint for the day that helps lower anxiety and prevent meltdowns.
How do they do that?
By making expectations clear and predictable. They provide a sense of control and understanding of what comes next, which is incredibly calming for someone who struggles with transitions or uncertainty. These schedules can take many forms, maybe actual photos for more concrete representation, simple line drawings for slightly older children, or even physical objects representing an activity, like a cup for snack time, for very young or concrete learners. The key is consistency in using them and keeping them simple enough to understand.
And what about devices or systems for communication?
AAC, Augmentative and Alternative Communication, or AAC, devices and systems are also incredibly beneficial, often opening up entire communication pathways for those who are nonverbal or have very limited speech. These include low-tech options like PECs, the picture exchange communication system where children learn to exchange pictures to communicate their wants and needs. It's very structured.
And high-tech.
Yes. High-tech options like dedicated GoTalk devices with recorded messages, or iPads with specialized communication apps like Proloquo Do or TouchChat provide a voice for those who cannot speak verbally or whose speech is very difficult to understand. It's often recommended to use a total communication approach,
Total communication.
meaning incorporating sign language alongside verbal attempts and AAC use. Providing multiple avenues for expression maximizes their chances of being understood and reduces frustration. For example, a child might use a sign for more, point to a picture of crackers on their AAC device, and maybe make a sound approximation, all at once to communicate their desire. We support all attempts.
Okay, let's just focus to school. How can the educational environment be optimized for children with DS-ASD? It seems like a standard classroom might be really challenging, and that a structured approach would be particularly important.
You're absolutely right. For school to be truly effective, supportive, and not overwhelming, it absolutely needs to meet the unique needs of the child, which are often complex and highly individualized for someone with DS-ASD. This often requires a structured teaching curriculum and classroom environment.
Like the TCH model you mentioned.
Exactly. Approaches like TCH, developed at the University of North Carolina, are often very beneficial. TCH emphasizes strong visual structures within the classroom, predictable daily schedules, consistent routines for activities and transitions, and clearly defined, distraction-minimized workspaces for independent tasks. It makes the environment understandable.
And without that structure.
Without this level of organization, predictability, and visual clarity, school can feel chaotic and overwhelming. A lot like torture, as one source put it, for these children. This can lead to increased anxiety, sensory overload, frustration, and significant behavioral difficulties, simply because they struggle to understand expectations, navigate transitions, or filter out distractions. Structure provides safety and promotes learning.
Now, here's where it gets really interesting, and you touched on this, the practical side of getting support in school. You mentioned claiming the diagnosis. Can you elaborate on why claiming the autism diagnosis specifically on an individualized education program, the IEP, is so important?
Yes, this is a critical insight for parents navigating the school system. Claiming the autism diagnosis on an IEP can often unlock the door for significantly more services and support.
Why is that? More than a Down syndrome diagnosis alone.
It's often due to how funding and service eligibility are structured in many school systems. An autism eligibility category on an IEP often triggers access to different funding streams and mandates certain types of support that might not be as readily available or as comprehensive under an intellectual disability or developmental delay category, which might be assigned based on Down syndrome alone.
Like what kind of specific supports?
This could include things like more intensive one-on-one aid support, access to specialized classrooms designed for students with autism, which often incorporate structured teaching like Teachy, a higher frequency or intensity of related services like speech therapy focusing on social pragmatics, or specific behavioral supports like a functional behavior assessment, FBA, and behavior intervention plan, BIP, implemented by staff trained in autism strategies. Parents have reported that adding the autism diagnosis can, in essence, supersede the Down syndrome diagnosis in terms of driving the intensity and type of services received.
So it's a powerful tool for advocacy within the school system.
It really is. It gives parents and the IEP team stronger justification for requesting and implementing the specific evidence-based supports that are known to be effective for learners with autism, tailored, of course, to the individual's needs within the DS-ASD profile.
That's a crucial practical point for families. Lastly, in this section on support, let's talk about something that can be incredibly distressing for families when it happens. Developmental regression. What does that mean in the context of DS-ASD? And what should families look for? It sounds terrifying.
It can be very frightening for families. Regression is defined clinically as a significant loss of behavior or skills that had been well established for at least several months.
Loss of skills they definitely had before.
Exactly. Skills they were using consistently. This could be a loss of verbal skills, maybe losing words or phrases they previously used communicatively. It could be a loss of motor skills, perhaps a sudden inability to walk steadily, climb stairs, or feed themselves when they could before. Or a loss of social skills, maybe a sudden withdrawal from interaction they once enjoyed, or loss of eye contact.
And the key is that it's unexplained.
Yes, the most important aspect, and this is crucial for diagnosis, is that this loss cannot be found to be explained by other issue, meaning it's not clearly due to an acute illness, a significant injury, a major medication change, or a temporary disruption in routine or environment. It seems to come out of the blue or gradually fades away.
So does it happen often? And when?
Research suggests about one-third of children with DS-ASD have a documented history of regression, which is actually a rate comparable to children with autism without Down syndrome. However, a key difference is the timing. In DS-ASD, regression tends to occur later, often peaking around 4 to 5 years of age, sometimes even later in adolescence or early adulthood. This contrasts with autism alone, where regression, if it occurs, typically happens earlier, often around 18 months to 2 years.
Why does it happen? Are there known triggers?
The exact causes aren't fully understood, but regression often seems to occur during times of significant changes or stress. These could be major life events, like starting or finishing school, the death of a loved one, moving house. But sometimes it can be triggered by seemingly minor changes in daily routine that might be particularly jarring or destabilizing for an individual with DS-ASD's need for predictability.
And if parents see signs of regression?
If regression is observed, the absolute first step, as we emphasized earlier regarding medical rule-outs, is critical. You must rule out underlying medical causes. This should be a priority evaluation with their pediatrician and potentially specialists. Things like undetected seizures, especially subclinical ones, worsening thyroid problems, autoimmune conditions, or other systemic diseases need to be thoroughly investigated. Because sometimes treating that underlying medical condition can actually lead to the recovery of lost skills. Don't assume it's just the autism or Down syndrome. Check medical first.
That's vital advice. Okay, this raises an important question then. Moving beyond the clinical details, the diagnoses, and the specific support strategies, how does this dual diagnosis truly impact families? Families like those in Cairos clan, on an emotional and practical level. What is the lived experience like?
That's such an important dimension to explore. The emotional impact is profoundly varied and deeply complex. As I mentioned briefly at the start, many families report experiencing a significant sense of relief when they finally receive the DS-ASD diagnosis.
Relief, that might sound surprising to some.
It might, but it often comes from finally having an explanation. It brings immense understanding, it validates their instincts, perhaps things they've been seeing for years that didn't quite fit the typical Down syndrome profile. And it can open doors to more targeted support and even funding. It helps explain behaviors they've been struggling to understand. As one parent put it in a resource we reviewed, he's still the same person. It just helps explain some of the behaviors we were seeing and gives us a path forward. It provides clarity.
Okay, so relief from uncertainty, but there's another side too.
Absolutely. For other families, especially if the autism diagnosis is less expected or comes later, it can feel like a second wave of grief. They might feel like another significant, potentially lifelong label has been added, or feel overwhelmed, thinking they were just getting a handle on Down syndrome, and now this was added to our plate. It's really extremely variable and extremely individual.
Can families feel both relief and grief?
Definitely. A family can feel both sets of emotions, relief and understanding, alongside a renewed sense of challenge or sadness at different times during the process, sometimes even simultaneously. It's complex.
I can imagine that this unique position, being sort of between two distinct diagnostic communities, could also lead to significant feelings of isolation for families. Is that common?
What's truly compelling here, and consistently reported in surveys and family accounts, is how many families indeed report feeling isolated or alone. They often describe not feeling like they fully belong to either the traditional Down syndrome community or the autism community.
Caught in the middle.
Exactly. Feeling caught between two camps. Despite having shared experiences with both groups, they often feel their specific challenges, the unique interplay of DS and ASD, are not fully understood by either group. This highlights a critical need for specific support networks and resources tailored explicitly to DS-ASD families. Finding others who truly get it, who live that same intersection, can be incredibly validating and life-changing.
In navigating the practical side, the system with a dual diagnosis must add yet another layer of complexity, particularly thinking about different resources, therapies, funding streams.
It absolutely does. Many families report feeling overwhelmed, not just by the diagnosis itself, but by the arduous process of navigating the complex healthcare and educational systems, especially when dealing with potentially separate funding sources, different eligibility criteria for services, and extensive, often repetitive paperwork for different agencies or programs.
More challenging than navigating for Down syndrome alone.
A comprehensive survey of families revealed an overwhelming response, indicating yes, they perceived raising a child with DS-ASD as significantly more challenging in many ways than raising a child with Down syndrome alone, often due to the increased complexity of needs and the difficulty accessing appropriate integrated support.
It sounds like a full-time job just managing the logistics.
It really can be. This added burden often leads to a common desire expressed by parents for help managing appointments, coordinating therapies between different providers, and handling all the administrative tasks, a frequently voiced need for a secretary or case manager, given the already substantial demands of caring for a child with complex needs. The separate funding streams, sometimes seen maybe state developmental disability services for DS-related needs, and separate autism waivers or insurance mandates for ASD-specific therapies, can be particularly difficult to manage effectively, requiring immense parental effort and advocacy.
Despite these profound challenges, though, there's often immense strength found within families and communities facing adversity. What about the power of community and specific support for DS-ASD families? Where can they find that vital connection and shared experience you mentioned is so needed?
The need for more tailored information and support, including specific parental support groups, is strongly reported by families, and thankfully it is being increasingly addressed by dedicated organizations and initiatives. Specific support organizations like the Down Syndrome Autism Connection are invaluable resources.
What do they offer?
It's primarily an online national support group, and they have private Facebook pages specifically for families navigating a dual diagnosis. This provides a safe, moderated space for sharing experiences, asking very specific questions, celebrating successes, and offering crucial mutual support with others who understand the day-to-day realities.
Are there local options too?
There are growing local support networks and specialized programs emerging in some areas. For example, the Down Syndrome Connection of the Bay Area offers consultations with DS-ASD specialists and facilitates peer support groups. It's worth checking with local Down syndrome organizations to see if they have specific DS-ASD resources or contacts. Helpful literature, like the comprehensive guide When Down Syndrome and Autism Intersect we mentioned earlier, and personal journey books like A New Course, A Mother's Journey Navigating Down Syndrome and Autism, also provide vital guidance, validation, and shared experiences, helping families feel less alone.
And it's important to remember the positive side too, right? The strengths.
Absolutely. It's crucial to underscore that despite the undeniable challenges, it's not all doom and gloom. An uplifting finding from one survey showed that a significant 38% of families said that raising a child with DS-ASD made us a stronger and more empathetic family. It emphasizes the profound positive impact it can have on family resilience, compassion, perspective, and appreciation for the unique strengths and joys each individual brings, dual diagnosis or not.
So what does this all mean for you, our listener in the Cairos Clan community? We've taken a really deep dive today into the complexities, but hopefully also into the clarity that comes with understanding DS-ASD. We've explored how this dual diagnosis presents differently, the historical misconceptions we've thankfully started to overcome, the updated prevalence showing it's not rare, and crucially, the actionable ways you can support your loved one through tailored strategies, effective advocacy, and community connection.
And if we connect this to the bigger picture, it's a powerful reminder, isn't it, that every single individual is unique, a complex and vibrant person, far beyond any diagnostic label. A diagnosis like DS-ASD is not a definition that limits possibilities. Instead, think of it as a pathway, maybe a blueprint, if you will, to better understanding, more targeted support, and more effective tailored interventions.
So it's about empowerment through knowledge.
Exactly. It's about empowering caregivers like you, the experts on your own child, to be the most informed and effective advocates for your loved ones. It's about seeing the full, vibrant person behind any label, appreciating their unique strengths while understanding and supporting their specific challenges. And the really hopeful part is that the ongoing research and the increasing awareness mean that the landscape of support and understanding for DS-ASD is constantly evolving. There's new hope, innovative therapies are emerging, and possibilities for individuals and families are expanding all the time.
Thank you so much for sharing all that expertise and insight, and thank you for joining us on this deep dive Cairos Clan. We truly hope this has provided you with valuable insights, perhaps a clearer path forward, and the confidence to advocate effectively for your loved one.
Keep asking questions, keep seeking support.
Absolutely. For more resources specifically curated for your community, including links related to today's topic, and to listen to more episodes of the Golden Scarab podcast where we delve into critical topics just like this one, please visit www.cairosclan.com. Remember, understanding is always the first step toward powerful, positive change.